Welcome back to the Doc Talk podcast. I'm Dr. Sheila Wijaya-Singha, a family doctor in Toronto.
And I'm Dr. Shazma Mathani, an ER doctor in Edmonton.
And so today we're continuing, Shaz, with our parallel season of the Doc Talk, recapping season 1 of The Pitt, which has become one of our favorite medical drama shows ever. Shaz and I both love it for its accuracy and the way it really gets to the heart of what we do as clinicians. And so this week we're doing a double header of episodes 2 and 3 recaps to get us ready for the new season that's launching in January 2026. And so going forward, all our recap episodes will cover 2 episodes from season 1 so that we can catch you up before season 2 starts.
And if you're just joining us, each episode of The Pitt represents 1 hour of an ER shift. So episode 2 is from 8 a.m. to 9 a.m. and episode 3 is from 9 a.m. to 10 a.m. So compared to the pilot, these 2 episodes really slowed the pace down, but gave us more heart and character growth, plus some of the most gut-wrenching ER realities, the opioid crisis, racism in medicine, advanced directives, and a trainee's first patient death. So let's get into it and start with episode 2.
So episode 2, we start open with the line, "Just another day in paradise," which really just sounds like it might as well just be the ER motto.
Yeah, honestly, the dark humor in this show really just illustrates how we survive in the emergency department with all the terrible cases that they see. You know, like Dr. Mohan later says, we need to laugh, otherwise we'll start crying. That's how I feel on the regular.
Yeah, that's a real sentiment in medicine, isn't it? Like you have to find these moments of levity sometimes because it is really hard and it's very real and it hits us in the heart. You know, so what we want to do, like we do with every other episode that we're recapping, is go through cases because we find this really interesting. And then I get to ask you, Shaz, how realistic is how they are approaching these cases in the emergency room? So the first big case that we're seeing in this episode is the opioid overdose. So there's like the classic symptoms that we're seeing of the pinpoint pupils, the slowed breathing, the unresponsiveness. Narcan is given, but the patient actually never regains brain function. From the ER side, Shaz, like what was realistic here and what wasn't?
So medically, it was very accurate, like right down to the toxidrome, the so-called kind of triad of opioid overdoses with the pinpoint pupils, decreased level of consciousness, and the decreased breathing, and the chaos of kind of managing a crashing patient. And then, of course, like, I don't know if you noticed this, Sheila, but like as they were bringing that patient into the room, the next thing you could hear the overhead page for like another tier 1 trauma rolling in. Like that part was very accurate. Like one sick patient coming in, the medical part of it was very accurate. You're already hearing an overhead page for the next sick patient that's coming. But the one thing about this case that had me yelling at the TV was the declaration of brain death in the ER. That is not something that we do. Brain death is something that's determined in the ICU, and it takes like hours to days, not just, you know, over the course of one shift even, or like 1 hour in this episode. And so that was something that was not accurate at all from my perspective.
Oh, really? Okay, that's really helpful to know because I was like, that seemed like fast, but that's helpful to know. It was also one of the most of many harrowing moments of The Pitt where when the mother is told that her son had died, and it echoed throughout the emergency room, and it was so haunting. Like I was inconsolable watching that.
Yeah, so I actually went back to listen to that clip yesterday to prepare for our recording, and it got me like full out sobbing again. This one really hits. Like one of my biggest fears in life after becoming a parent is being in that mom's position. And it really doesn't matter how old your child is. Like losing a child, I think as parents is one of our absolute biggest fears.
I mean, I feel like we also need a moment here. Like this is such a visceral moment in this episode. And I actually was sort of nervous to rewatch this episode for that reason, because I know how much like that hit me. And I remember hearing that sound in the emergency room when I did my shifts as a resident and as a medical student. And it's something that you never forget that feeling. And again, like you said, Shaz, so beautifully there, like as a parent, this is your worst nightmare happening.
Yeah. And I have to say, like, those are the cases where I like still like, because I've had cases like this in real life, both in the pediatric ER, so with young kids, and then also in the adult ER with, you know, like 18 to 25-year-olds where, you know, typically the parents were still very much connected and involved. And honestly, like even older than that, like we always say a parent should never have to bury their child. And so these are the sounds, there's nothing that will ever be able to get the sound of sobbing parents out of my brain in these situations. I have like a handful of cases and they just like stick with you for life, because like you can absolutely feel the agony that they're feeling in those moments.
And then to have to move on to another patient after witnessing that, how do you do that?
Yeah, so that stuck with me with this episode, because it is absolutely accurate. In the ER, you can go from telling a mother that her son has died to walking straight into the next room where another patient needs you. And there's really no time to decompress. There's no time to, take the more than just a moment that you need to recover and kind of compose yourself again after that. But like, that is what we do, because there are dozens and dozens of other patients in the ER that need care as well. And so that's I mean, I think they did a really, really good job of illustrating that tension that we face every time we have to break bad news.
Absolutely. And online as well, I think this moment really resonated with a lot of people who've been watching the show. And one that really stood out that I saw online was a quote that really, really hit, where it said, "I had an uncontrolled emotional reaction to the mother's wailing. That particular tone of distraught screaming when a mother is told her child has a non-survivable injury is something you never forget." Yeah, really resonated. And yeah, like you said, Chaz, we don't forget that sound. So let's take a moment and take a breath for ourselves here and go on to another case that we was also very interesting. And I think it's something that you actually talk about often, Chaz, in your social media, on your account, around the scooter versus the car door trauma. And, you've posted about e-scooter injuries before. This is actually one that my husband actually had to walk out of the room because it was so graphic, the fracture, the facial fracture.
Yeah.
So how realistic was this injury and what you see?
Well, I'm just going to take a side note and say that this is exactly why I tell people not to get on these things. It's not even just so like this was a facial fracture, right? So a helmet probably would not have stopped this from happening. Of course, we see like limb injuries as well, like severe fractures, what we call open fractures, where the bone is literally sticking out through the skin. This one was a very complicated and severe facial injury, and it was very realistic. Like the way it was portrayed with that, what's called a Lefort 3 fracture, which is where like basically the upper part of the teeth, like that part where it's around like your nose and your upper teeth, are disconnected from the skull. And so like you could see them like pulling that forward and it was disconnected, which is like diagnostic of a Lefort 3 fracture. And then I also love how they did the airway double setup, because that is exactly what I would do in that situation.
So can you explain that to our listeners, Chad, and to me? What is an airway double setup? Yeah,
so an airway double setup means that you're kind of preparing for two different airway strategies at once. So typically when we have to intubate someone or put a breathing tube in for a multitude of different reasons, in this case, it would be that they're what we call their predicted course. So they may be, breathing right now, but as that facial swelling gets worse, as their injuries kind of get worse, then they may be at risk of aspirating or not being able to continue to breathe normally. And so in a normal situation, the first choice is always to put a breathing tube in, what's called intubating. However, there are some situations where intubating is very, very high risk and could lead to a high chance of failure and then not being able to kind of secure that airway. And so in those situations where we might predict that an intubation is difficult, we do what's called a double setup, which is where somebody does still try to intubate, but then someone else, a second doctor, has the neck kind of prepped with sterile solution, has everything draped with all their tools ready to go, because if that intubation fails, you cut, which is what they did in this situation, where you kind of cut through and put a temporary airway in through the windpipe through the neck here, so through the cricothyroid membrane. And the thing that really stood out to me was that very accurate, doing the double setup, because that is 100% what any other emerge doc would do in this situation, but also allowing Dr. Mel to do the procedure with the two senior doctors supervising and still giving learners a chance to do the procedure as well, kind of with the safety of having these senior supervising doctors who have done it, who can troubleshoot with them, and then also give them the opportunity to learn how to do this life-saving intervention.
That's so interesting. Again, I don't know how you do what you do.
It's
I'm clearly meant to be a family doctor.
Yeah, that is a very rare procedure. I've done 2 in my entire 15-year career if you count residency. And you only hear of like another handful of them as well, because it is a very rare procedure. We do double setups, not that uncommonly, because like just as a just in case, but as emerge docs, we are very, very experienced intubators. And so for the most part, we will get the airway from the top, like from through the mouth. Yeah. But that's just as like a backup.
Wow. Then we move on to another case that actually is quite a big theme throughout the next couple of episodes. It's the nursing home pneumonia situation where there's a patient who's been brought in with pneumonia. He has advanced directives that he has already agreed to, but his daughter wants to override it. And honestly, it's just like, this is one of the worst places to have this discussion, but it happens so often in the emergency room. I try to do this in my own family practice office often for my patients of all ages. I'm like, let's talk about your advanced directive so we know what you would want to happen if you were in a situation that a decision had to be made about your care. How often does this situation happen, Shaz, where you see family members want to override that clear advanced directive?
It happens a lot more common than unfortunately, I think it should, but it makes sense because families very much struggle when they're in crisis. You can see that struggle taking place between the son and the daughter, like the brother and sister that are here. They clearly love their dad. It's hard to it's hard to follow through on decisions like that, right? I mean, like I'm just trying to put myself in that position as well. And, legally you can't override an advanced directive, but practically these conflicts still happen in the ER. And it's one of the hardest positions to be in as a physician. And like from a legal standpoint, because the son and the daughter are have kind of the power of attorney.
Yeah.
They actually can change it. They like the way that it works is that you have ideally talk to your family member first about their wishes and then you carry them out. But in these really challenging situations where emotions are high and things are in crisis, I have seen situations like this.
Yeah, so this gives us like an opportunity because I think one of the best things about the Pitt is that there's a little bit of like PSAs, like public service announcements that happen throughout all the episodes that I think really hit home around what we try to educate our patients on. So what we want to do for you, our listeners, is start doing something called a little mini teaching corner. So we're going to do a little teaching corner here around this case. So Shaz, can you share a little bit about what an advanced directive is?
Absolutely. So an advanced directive is a document where someone kind of outlines their wishes specifically for medical care if they can't kind of speak for themselves or make decisions for themselves. And so some examples are, not having CPR done, not having intubation done, not having ICU admission, and then on the other end of the spectrum, kind of having comfort care only. We often see this in patients who are older or have like a palliative cancer, for example. And in theory, it's there to provide care and to carry out your wishes as an individual from the medical standpoint when you don't have the ability to articulate what those kind of care choices are in the moment.
Yeah, and that's where the challenge comes up, like you said, when families may disagree, and suddenly you're having a life and death argument in the middle of the ER, as what happened here in this situation, and that's very difficult. Like we see this all the time, unfortunately, because it is such a crisis moment for families, and understandably such a difficult thing. Which is why, actually, I always tell my patients, it's a good thing to have clarity around this before you're in that crisis moment, which inevitably many of us will be in. And that's something that's very kind to do with your family, but things do change in that moment.
Yeah, and exactly. That's exactly it, Sheila. The takeaway here for me is to talk to your loved ones early when they are, of clear mind and can have these, because there is nuance to these conversations, right? So like to have these nuanced conversations, to be able to write down their wishes, even for you as an individual, like talk to your to your partners, your spouses, whatever, your children, if you're an older individual, so that they can carry out your wishes when you can't. Don't leave it for your kids to fight about in the middle of an ER shift, because that just isn't, it's sad for everybody in that scenario.
Yeah, absolutely. Another powerful case that we saw this time was a patient who came in with sickle cell crisis, and they were dismissed as drug seeking. And, I love that they didn't shy away from showing us how racism happens in medicine and medical settings. And this is why sometimes our healthcare settings are not safe for patients because of the systemic racism that exists not only outside in society, but also within our hospital walls.
Yeah, this one was painfully real for me. Sickle cell crises can cause excruciating pain. They can be life-threatening if you don't manage the pain effectively. And Black patients are too often doubted and undertreated when it comes to this disease. I love Dr. Mohan's line here about reassuring the patient that she was safe. It was just so authentic. She, kind of got down and talked right, like face to face with the patient and just really provided that reassurance that she was safe here. Yeah, I mean, so working in an intercity ER, I often see the same with racialized and Indigenous patients. The stigma is absolutely still a barrier that keeps people from seeking care. And so seeing Dr. Mohan stepping up, seeing the patient and taking control of her care was such a powerful moment for me.
Me too. I see this often, and a lot of my patients in the family practice side are fearful of going to the hospital for this reason because they've been poorly treated. And so it really has impacts in people accessing care when they're treated poorly. And it's something that we're trying to address daily with anti-Black and anti-Indigenous racism training that's happening now. And so I really appreciate that they highlighted this because it's a very real thing that happens and it really affects how people are cared for. And hospitals should be safe spaces for people. There's a lot of serious pieces to the Pitt, but thank goodness there are moments of comic relief. So, we have Earl, the patient who's often in the emerge. We clearly know that he's in the emerge often. He's always asking for a sandwich, so people are often getting him a sandwich. Robbie being called a fruitcake by one of the patients. And of course, one of my favorite lines that happens is around rats.
Patient tested positive for rats. Like, I don't know about you, Sheila, but there was something about the way that Whitaker said that and just like, off the cuff, just like without missing a beat, patient tested positive for rats. And I just like burst out laughing at the screen. Matt's looking at me like, what is happening? Why is this so funny? And like, to be honest, we need these moments to survive our ER shifts. Without, again, to the line that Dr. Mohan said earlier, if we don't laugh, we'll cry. And that is so accurate. So I love how the show like weaves in all these pieces of comic relief. Dr. Mel is another good example of just her awkwardness, but like her, like just the way that sweet. She's so sweet. But then, the high fives to everybody of just like, just so,
and she calls it out too. Like she says, when I get nervous, I make jokes, right?
Yeah,
like it's sort of her coping mechanism.
Yeah. And I also love how episode 2 kind of deepened those characters. So as you said, when Earl was asking for a sandwich, you see Whitaker kind of sneaking an extra sandwich, Mel King sharing about her mom's death, Santos' strained relationship with her own mom, and then Collins with confirming her pregnancy. And then, of course, the nicknames, ER Ken, Slow-Mo, Crash, like they're all, most of which are from Santos. They're pretty great to just lighten, like provide some levity in these pretty serious cases.
Yeah, I really feel like this episode reminded us that healthcare clinicians and healthcare providers are human too. And, while we're often caring for our patients, we're often carrying our own struggles, like Whitaker, like you said, taking a sandwich for himself, and Collins having this pregnancy. Like there's a lot of these pieces that we kind of have to put ourselves aside in these moments to best care for our patients, but we're still carrying our own struggles.
And so the end of this episode, the episode 2, 8 a.m., ends with Dr. Whitaker's patient having a cardiac arrest. And the end is us kind of like just seeing him providing chest compressions on this patient. And then kind of the scene goes black. And so let's start with episode 3, which kind of picks up right where episode 2 left off at 9 a.m.
Yeah, so episode 3, 9 a.m. It starts with Whitaker, as you said, Shaz, doing CPR, and they took us right back into that moment where he's doing CPR on his patient that he had originally diagnosed with gallbladder issues, and the nurse had actually chimed in and said, why don't we do an ECG? And we talked about that in our episode 1 recap, that, nurses know a lot, and they're excellent, and they're great clinicians. So how accurate, Shaz, was that CPR scene?
I would say it was fairly accurate. So even just like discovering him, kind of the end of episode 2 to episode 3, him discovering the patient, trying to wake them up, yelling and calling for help, that absolutely happens. Because we do find patients who are in unmonitored areas, not in recess rooms that end up crashing in some way. And then somebody goes to check on them and asks for help. Somebody has a seizure, for example. You yell for help to try to get anybody there as quickly as possible. The rib cracking that occurred, you could hear it, and then he said that he felt the ribs cracking. That actually happens with good compressions. You want the ribs to crack. And I really liked how raw it was. Like, there was no music, no gloss. It was just the sound of CPR and the beeping monitor in the background, which is exactly how it feels. Lots of people in the room as well. Like, this is very much how cardiac arrests are run.
Absolutely. And it's actually fascinating because the show, a little bit of background information about the show production. So often on medical dramas, there's like music that accompanies these moments to kind of elicit more emotion. The production team purposely left out the music because they wanted it to be real. And I love that they did that because we didn't need any music to enhance our feeling of what was happening in that moment at all. And they actually even banned things like phones on the set and avoided music to let that raw emotion really land. And I think they were very successful in doing that.
I have to agree. It's not something that I noticed until you pointed it out to me, but like, you're right. There is really no background music, but like, you have the sounds of the ER all around you, right? And so that's like, I mean, the beeping, the overhead pages, people kind of talking around you, patients screaming down the hallway, like that is, it like really immerses you in that experience with the way that they did the audio.
So this was another big moment of the show where this was Whitaker as a medical student. This was his first patient death. And that is such a big moment in our medical careers. I remember my first patient death as well, Shaz. I'm sure you do too. Mm-hmm. And in this moment, Dr. Santos's words really hit me hard too.
Yeah, so this is like a moment of tenderness that we see with Dr. Santos. You're not a real doctor until you've lost at least one patient. She is someone who is just like stone on the outside, right? She really keeps like a hard exterior, and seeing this interaction that happens between her and Whitaker to try to provide some solace to him was really actually quite beautiful to see. And it is true. It's something that unfortunately comes with the territory of being a physician, no matter what kind of physician you are. Later in the episode, we see Dr. Robbie is kind of debriefing with Whitaker. And this is honestly the kind of teaching that I still use with learners.
Yeah, this was such an impactful scene in the case. And it took me right back into one of my first shifts as in the emergency room as a medical student. And one of the patients that I was caring for crashed and had to have CPR done. And the doctor that I was supervising me, he was so lovely, and he kind of took me aside and did a mini debrief, not as much as we saw on this episode, but it was really appreciated. But it was also very quick because there were patients to see. But I remember just sort of living through that experience, and then watching Whitaker doing the CPR on this episode really took me back 23 years back to that moment. So do debriefs like this actually happen in the emerge, Shaz, when people pass?
They do. So they might not happen right afterwards because of depending on what else is going on, but we really try to make it a priority to do a debrief while the people who were there are still on shift. And so we typically, it's not just single coverage in the ER from a physician standpoint. And what I mean by that is that there's always other doctors around. And so usually what we'll do is let the other doctor know that we're going to have a debrief. They kind of cover the department for a brief period of time so that we can go to a quiet part of the department with anyone who wants to be there. It's not mandatory. Anyone who wants to be there. So respiratory therapists, nursing, service workers, unit clerks, doctors, nurses, whoever wants to be there. The social worker is almost always present. And then we usually have, maybe like 10 or 15 minutes to say how things went, see if we, what we noticed, what emotions we're feeling. And then there's like support provided in that moment, then ongoing support that's offered for afterwards. So this does typically happen while you're still on shift to try to capture everybody that was there during these hard cases.
I'm so glad to hear that. Because that's such an important piece to understand that we grieve as well as when a patient passes. We have our next case. So getting into some of these cases, it's so interesting. We have almost a continuation of the previous case from episode 2 that we talked about with the opioid overdose, when a friend of that original patient comes in who's also overdosed. And this time, Narcan works.
Yes. So, you see them run out to the car. There's like a friend who comes in, help my patient. My friend isn't waking up, and they run out. They see the pinpoint pupils, shallow breathing, and they're unresponsive. And like Narcan comes out with them. And within minutes, the opioid poisoning is reversed and the patient's kind of sitting up and talking.
And so, Shaz, let's do another teaching corner because I think this is an important one. Why is Narcan such a game changer?
Yeah, so Narcan is like an antidote to opioids. So opioids bind to multiple different receptors in the body, including the brain and receptors that control breathing. And so what happens is Narcan will actually just kick those opioids off the receptor and prevent them from having an effect on that receptor anymore. And so overdoses usually kill because people stop breathing. And that's what Narcan restores almost instantly.
And it's not just for doctors to give, right?
Exactly. So in Canada, Narcan kits are free at most pharmacies. You don't need a prescription. It's easy to use. It's either a nasal spray or a muscular injection. And the kit has everything that you need in it. And anyone can save a life with it.
And this is so important because, as this episode showed, not every overdose is reversible in time, but carrying Narcan with you can be the difference between life and death. I have one in my purse. I have one in the car.
Yeah,
I wish you must have it too.
I have many. Yes, I wish every household had at least one. I keep kits everywhere, so I have one at home. I have one in my work bag and my bike bag. I even actually put one in Matt's work bag as well, just so that ideally you would never need it, but it's always there in case you do.
Now, we have a couple of quick ones that I thought were interesting, too, in terms of cases. There was the nail in the heart case, Shaz. So why can't you just pull it out? Because that is the instinct. So if you get a foreign body in your body, just pull it out.
Exactly. So here's the PSA. If there is some penetrating object like a knife or a nail that is in your body, just leave it because it might actually be plugging the bleeding. And so when you could see actually when they showed a close-up of the nail, it was like beating with the heart. And so that kind of indicated to the healthcare workers that were providing care to like not touch it. They kind of stabilized it with the 2 rolls and kind of put tape on it so that nobody was going to accidentally bump it because pulling it out could be catastrophic. And that's when you consider what they did, which is an ED thoracotomy, where they open up the chest in the ER. It's kind of a Hail Mary type of effort. And it's the one thing that kind of stood out to me about that was that it is almost never that quiet and controlled because there are a lot of people there. We often have surgeons coming down, learners kind of wanting to see this procedure because it is quite rare. And so it is it's controlled chaos, but certainly not typically as quiet as we saw in the show.
And so there was also the STEMI, so the type of heart attack, that's a very specific type of heart attack, and the door to balloon time was under an hour, basically. What's the Canadian standard, and what does that mean?
So I love that they talked about this to kind of just like how they turned like this moment to a teaching moment with Whitaker to also then inform the audience as well. I love how they do that, and they use that to kind of clarify the medical jargon that they're using in the moment. And so the Canadian standard is under 90 minutes. And so what that means is from the time a patient is diagnosed with a STEMI, so have an ECG done, every minute counts because as Dr. Robbie says, time is myocardium. And so every minute that heart muscle is not getting oxygen, those cells are dying. And so the door to balloon time is the time that they come in to the time that they have a catheter put in and the balloon is inflated to open the stent up into the artery that's blocked. And so 90 minutes is not very long. And so that's why with these hospitals, like with tertiary care hospitals, like it is like the timer starts as soon as you walk in the door because everything has to be like there are protocols in place where everything is all lined up so that you can get the patient to the cath lab as quickly as possible.
Yeah, Langdon was super excited during this part. Like he was like really into beating that time clock, which really tells you like, I feel like emerge docs have a bit of a competitive edge. And it was very clear in this, not that you don't have that competitive edge, Shaz, but I think you might have a little bit of that competitive edge where he was like excited to be like, we're going to do this. We're going to like get him there in time.
See, now I have an excuse to Matt as to why I'm so competitive because I'm an ER doctor. That's why.
It's exactly what it is, right? Episode 3 also helped us a little bit with further character development. And they were like very subtle, but like really powerful moments during this episode that I loved seeing. Dr. Robbie pausing between patients. We mentioned that earlier. Like we don't have a lot of time between patients when you're going from one room to the other. And him taking that audible deep breath before moving on. It's like that emotional reset that you need when you're in the emergency room.
Yeah, those scenes of Dr. Robbie or like Noah Wiley and how he portrays him is so good. And you and I have talked about this before, but he is so good at non-verbally portraying the breadth of emotions and turmoil that emerge docs go through in every shift. And so This one was so real. It really resonated. You kind of carry the last patient with you, but you also need to be fully present for your next patient, right? There's so many other patients that need your attention and deserve your attention. And so kind of that immediacy of being pulled right back into the chaos with no time to grieve, that was captured really, really well. And like certainly does add to a lot of that character development, like you said, that we're seeing.
I really loved also how he told everyone to like keep an extra eye out on Whitaker today because of what he went through with his first patient loss. And it was such a lovely way to like express this sense of family and looking out for each other. It was really beautiful.
There's one particular line that really stood out to me when Dr. Robbie was having a conversation with Dr. Mohan about kind of speeding things up and kind of calling her out on being worried about making mistakes and saying, you know, you're going to like, this is part of being an emerge doc is just being able to accept that you're going to make a mistake. And like when I describe this to my learners, that is exactly how we talk about it in the ER, because we know like, we are human, right? We are fallible and nothing is 100%. And unfortunately, practicing medicine in that way is not an effective way to care for as many patients as possible.
Yeah, I found that really interesting because it does make you reflect on like who goes towards emergency room medicine, who does family medicine. I couldn't be an emergency room physician myself because I sort of I spend extra time. I'm like Mohan in that way where she's like getting the backstory, like tell me where you grew up and all these pieces, which are such a beautiful part of knowing your patients. And I'm sure that you wish that you could do more of that, Shaz, but practically speaking, when you have a waiting room full of people, you just can't.
Nope, you really can't. So, and like there's a lot of uncertainty in emergency medicine.
Yeah, that doesn't work for me very well either. We have some in family medicine, but not as much as you do in emerge. So we love to also like look at like what our favorite lines were this week. So what was your favorite line of these past two episodes, Shaz?
So for me, it was that interaction between Collins and Santos, where like Santos is like, can I do a chest tube? And Collins is like, well, is there a chest tube? And she's like, well, no, but like any chest tube. And Collins kind of talks to her about how like, you know, it's great that you're confident and ambitious, but you need to have humility as well.
Boom. Right? Like,
yeah. And it was like, that was one where I'm like, yeah, Santos needed to like hear that and like just be taken down one little notch, just as a little reminder to like, to have that humility that is very, very much necessary in medicine.
Yeah. Be excited, but also be kind and respectful. And Shaz, who were your MVPs for episode 1, 2, and 3?
So for me, MVP was Dr. Mohan for her empathy towards the sickle cell patient and honestly calling EMS out on their dismissiveness of her and of the patient, and really just kind of anchoring and labeling like these are things that happen so much in medicine. And I think bringing awareness to it and calling it out is a really important way forward.
Absolutely. My MVP for these episodes is Mel King. So she continues to grow in my heart every time I see her. She did the crike. She did the procedure well. She has a sense of humor. She keeps levity within that chaos that's happening. And then I love the scene when she's outside and she's like hyping herself up. And I feel like we all need a little bit of that to be able to kind of like move on to the next patient, to build that confidence. I loved it.
The part about that like I loved the most is you don't necessarily expect that from Mel. No. Only on episode like 2 or 3, I can't remember, but like it like in that moment, she seems pretty straight-laced, right? Like you don't kind of get that kind of an impression from her until you start to, because this is like then huge in terms of her character development, and you really get to like see this window into her, and it's just like so authentic and real and just like so sweet. I loved everything about that scene. It was just so good.
She's so great. Yeah. I also like some special MVPs for me were Dr. Robbie, his balancing of compassion and chaos from supporting Nick's parents when he told them that he had passed, to the veteran's sister. That was such a beautiful moment when he read the letter, and it just like, it was so lovely how he gave that time. And those times, you don't have a lot of time in the emergency room, but he knew that she needed that extra. She needed it. And so he gave it to her. And I think those are parts of like, you must feel that often.
Yeah. I mean, absolutely. Because that's exactly what stood out to me. Like there's so much chaos. You're being pulled in so many different directions, but in the moments where patients need a little bit extra of your time. And I'm more than happy to sit down, look at them face to face, and provide those extra few moments to give them what they need during their stay in the ER. Mm-hmm. Another one is Whitaker and his first patient death, right? That was so raw, human, unforgettable. I mean, you and I immediately can go back and remember. It's like something you never forget, right? You never forget the first patient that dies under your care. And it was very, very well portrayed and really kind of hit at the heart for sure.
And what was your most relatable moment, Shaz?
Hearing Nick's mom screaming when she finds out that he's gone, because I not only relatable from a provider standpoint, like having been in situations like that where you can, hear that raw agony, but also just as a parent trying to like put myself in those shoes and it being like, as I said earlier, just like a big fear of mine since becoming a parent.
Yeah, absolutely. A quick honorable mention to a relatable moment is when Robbie gets interrupted regularly when he's trying to go pee. I mean, I feel like you just have to hold it sometimes, but he was constantly interrupted when he was even at the stall to go pee. And that was such a classic, it's like relatable thing.
Yeah. It's like a running joke that we have in the ER of like, yeah, like, do you even pee? No. Like maybe I pee once a shift, but like there's times where I'm like finally getting home after like 10 hours and I realize that I haven't peed and I walk in the door and I'm like about to pee my pants, because in that moment then I like finally remember, I had to pee hours ago and I just like forgot or couldn't get there.
Oh my gosh. What was the most accurate medical moment, Shaz?
Yeah, for me, the most accurate medical moment was the STEMI. So that heart attack patient where even the ECG, down to like they pan the camera to the ECG, even the actual ECG findings were bang on, kind of focusing on that door to bloom time. That is exactly kind of how things would go in the ER in those situations. What about you?
Oh, I love that the rat scene. The patient tested positive for rats. I feel like I've seen that happen. It's not inaccurate. That's actually quite accurate. Some of our patients live in situations where there are rats and they come in with them. And so that was a nice moment of levity and quite a strong emotional 2 episodes.
Mm-hmm. Yeah, it was nice to have those moments of levity for sure. Any take-home messages today for our listeners?
Yeah, so I think our prescription that we usually do at the end, Shaz, like I think when we're keeping up that theme as well for this, our prescription for everyone listening is to talk to your family about your advanced directives. Don't leave those decisions for the emergency room and consider carrying Narcan.
Mm-hmm. And for me, as an ER doctor myself, I hope that our listeners remember that emergency medicine is unpredictable, heartbreaking, and sometimes funny, kind of often all at the same time. Like the scene that stands out for me is after Whitaker's patient is pronounced dead and him and Mel are just standing in the room and she's like humming to herself. He's like clearly distraught. She, like it's just, she talks about how like death makes her uncomfortable or like losing patients makes her uncomfortable and then makes like a little pathologist joke in there. Like all of that together at once is, it really embodies what emergency medicine is.
Mm-hmm. So episodes 2 and 3 of The Pitt gave us resilience, breaking points, and more than a few gut punches.
So coming up, we will see the interns keep learning the hard way, Dana get tested again, and Robbie searching for ongoing meaning in the chaos. We'll see you in a couple weeks for our next recap on episodes 4 and 5.
And a reminder that the Doc Talk podcast is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And please be sure to follow us on social media at the Doc Talk Pod and send us your questions.